Good afternoon, everyone. I'd like to thank AIOC for giving me this opportunity. These are my financial disclosures. I'm sure each one of us had cases where you have done the perfect workup for a phakic IOL patient, you have done the perfect calculation. Even in the surgery, in the OT, the surgery has gone perfectly, and next day you see the patient also smiling, the patient is 6/6 vision, so you're also very happy. But when you look at the slit lamp or the OCT, you have a high vault or a low vault. Now, why does these kind of cases happen to us now and then? So this mainly happens is we rely only on the horizontal wide-to-wide, and also we do certain assumptions which we think it's always true. That is, the shape of the limbus is always elliptical, horizontal wide-to-wide is always maximum, vertical wide-to-wide is always minimum. And this is where things go wrong. Now, the research question is, can we actually think of a new formula where we can predict these vaults before surgery itself so that we get the perfect sizing? So to do this, we thought of an idea where we took the pentacam densitometry scan, and the values in 256 grayscale was plotted. The rate of change of the densitometry was noted so as to mark the wide-to-wide exactly, and this was done 360 degrees. And we found something interesting when we looked at this particular data. What we found was the shortest wide-to-wide correlated beautifully with the steep axis, which was very interesting, and we even published this data. But keeping aside this coincidental finding, basically the same way we calculated the max wide-to-wide, minimum wide-to-wide, max angle, minimum angle, horizontal wide-to-wide, vertical wide-to-wide. Now we took all of this data and also the data from the pentacam, the refraction, the ICL parameters, and also the UBM predicted wall size, and put all of this into an AI, and we found something very interesting. So if you look at the predicted vault, the coefficient of determination was 0.74. Basically, the closer to 1, the better it is. And also the interclass correlation coefficient was 0.92, which was extremely, extremely good. But let's look at all the literature, which all the formulas which are already there. So the R square ranges from 0.06 to 0.3, 0.4, and the best, which is the Lasso formula, where the R square is 0.68, and our new formula is performing even better than this. So to conclude, with the novel 3D corneal diameter profile and AI-driven ICL sizing, we are able to estimate the post-operative vault much more accurately with the R square of 0.74. That way, we reduce the chances of vault surprises post-surgery. That way, we give more confidence for doctors to start a phakic IOL practice, and also surgeons who are already doing less amount of anxiousness. Thank you so much for your time.
So the measurements which are fed into this are the pentacam measurements into the new AI formula?
Yes, sir. So the pentacam measurements are also added, sir. The what extra thing which we did is our own formula, that the 3D corneal modeling. So what we do is we take the data, the densitometry scan of the pentacam, we take that data, and then we look at the change in the rate of change and perfectly mark the wide-to-wide so that the errors don't happen. Because a lot of times, when you manually do it, errors happen. So we exactly measured the wide-to-wide, and we did this 360 degrees and then plotted it, so that we get that the exact axis of the shortest wide-to-wide. And this data normally we don't get everywhere, and the perfect axis also. Yes.
Very interesting.
Thank you. How many cases data? So this is this particular formula is based on 100 cases right now. We are adding more data. But if you look at all the published data, it's ranging from 100 to 120 cases, which is already published. But we have tested in a lot of patients, and it looks very promising. And definitely, we have to add more and more patients.
But tell me one thing: you're still placing your ICL in the same 0180.
Right.
So whether there is, the diameter is shorter somewhere else, or how does that help you in the sizing? Because you're not changing your, orientation.
Understood, ma'am. Absolutely, ma'am. So basically, so the information about the shortest wide-to-wide, and that was a different correlation to the steep axis, ma'am. But what we are doing with this data is this is a unique data which normally wasn't available for AI to read and predict, okay, look, if you have this kind of minimum white to wide or maximum white to wide, choose this ICL size. That is what the AI is doing. It's not predicting the position, ma'am. What it's trying to do is using new data so that the prediction of post-operative vault will change. Actually, moving forward, that is a very interesting point. Is that is what we want to do. The next is, I mean, unrelated to this, ma'am, but we are looking at what if we position toric lenses, be it toric normal cataract lenses, posterior chamber lenses, or phakic lenses in the shortest white to wide axis, so that you are perfectly aligning the steep axis. That is something that we are yet to come to, but as of now, we are using that data only for the AI formula to predict better the vault, post-operative vault, ma'am. Thank you, ma'am. Thank you.
Your results were validated?
Sorry, sir?
The post-op vaults were...
Oh, yes, that's the stats which I showed. So the coefficient of diffusion, it's basically, if you see that value, if it's closer to 1, the more accurate and more better it is. And we compared it with every other published data. We are right now one of the highest, and we feel it's going to be more stronger as we keep adding more data, sir.